Good morning, Vlad. Okay, we start in 20 minutes. What do I want? Yeah. Hmm. Good morning, everybody. Let's see, I got a rousing welcome.
Hello, John.
Good morning.
Vlad, how you doing?
Fine. About you?
Good, good. You like my background there?
Again, the same?
You like the background on the picture there?
No, I like the place. This is my den, and this is where I'm sit most of the time.
Oh, okay. Let me get off this here. Stop video, unpin video. Okay, very good. I think we should incorporate, like in the book, let's see, in the study with Vlad, a little feature with this, where we just pick out a book and you talk about it.
Yeah, you
And
may
you
take a look on the books.
And you don't pick it, we
And
pick
I've
it.
written it for you.
Yeah, I know. You don't pick the book, we pick it.
You can.
And then we try to catch you. You said
Not
you read
medicine
that.
at all. There is not a single medical book in behind me.
I know that says something. That's a statement there.
Yeah, it's a statement, actually.
Yeah,
Should we be in a hospital, there would be some.
yeah.
Not
That's
at home,
great.
though.
So how are things?
You don't use medical books anymore.
No, you know, it's you get out of the habit, you know,
Yeah.
and just reading. I don't know if it's affected you, but even reading, I don't do much of anymore. I used to read all the time.
No, we have the house is full of books, and when we go to bed with my wife, we just are lying and reading the readers.
Really?
Not any more books. But I don't know how to throw it away, how to get rid of books. That's something so, you know, alien to me.
Well, you know, there's nothing better than going into an old bookstore and getting lost.
Yeah.
And you never know where you're going to go. You never know what you're going to
It's
see.
expensive endeavor to go into a bookstore.
Well, I'm talking about the bookstores that aren't organized, that just have all these books, used books, you know.
Oh, yeah.
I think it's big in Europe.
Yeah, we call it antiquariat.
Yeah, it used to be big here. In certain parts of the country it is, but in the Northeast, that's the most literate part of our nation, the Northeast.
Yeah, there are many in Prague, but they don't buy books anymore because they do not sell much.
Right.
Yeah,
It's not a money-making business. You do it for the love of books.
Yeah.
If it's, you know, like when I had a bookstore called Kafka's, I told you that, right?
Oh, you did? You didn't tell me.
Yeah, it was a used bookstore here in Miami Beach called Kafka's.
And did it work?
Well, no, I was working in the hospital at the time, and I ran that store, but it was just good to go in there. The only people we could talk about books with were Europeans.
Yeah, mostly.
we couldn't do that with Americans.
That's true. No, it's still pretty popular here in Europe, the books. There are bookstores, not on each corner, but in Prague, we may have like 100 bookstores at least.
Really? It's the same, or is it decreasing? Decreasing?
No, it's decreasing.
Yeah,
decreasing,
it's
and they are pushed from downtown.
Right.
You know, by economy, because the rents are too high and the bookstores do not earn that much to keep these prominent places. So they are moving to the outskirts.
Yeah.
Which is a pity.
Yeah, it's a dying business.
They sell not only books, but they sell like old paintings, and they sell like old graphics and these things. And that's beauty sometimes.
Yeah, but there's one place in Georgia I went to once in Vidalia.
Yeah.
It had a huge book in the middle of nowhere, just a big bookstore, old bookstore.
Yeah.
It was huge. And I spent so much time in there just browsing around.
The same.
Yeah.
The same.
And you never know what you're going to bump into.
Yeah. And these people, they do understand books. Some of the owners of these antiquariats are really good.
Yeah, they do it for the love of books. They don't do it for profit.
And they must love it. Otherwise, they wouldn't survive.
Yeah.
And you don't become rich of it.
No, I heard of one in Wales. It's supposed to be the biggest one in the world, biggest used bookstore in the world. In Wales. It's supposed to be a huge bookstore. It's supposed to be very good.
You get everything.
Okay, well, I'll put on the beach for you. Is the beach better, or should I put the serious neurosurgery TV?
Yeah. John, I will disappear for a minute.
Yeah, go ahead. Good. Get your coffee. Is that me freezing, or is everyone freezing? Oh no. Oh no. Oh no. Oh boy. Okay. Okay, Vlad, just a minute.
Okay, I'm back with my coffee.
Okay, yeah, me too.
Yeah.
Yeah, I go to 7-Eleven across the street.
Hmm?
You don't have
You told me to
7-Elevens.
go across the street. We don't have shops here.
Oh,
I have nowhere to go for a coffee, but the kitchen.
Everything's closed, right?
Not close, no. We are living in a village, and the closest shop is like 2 kilometers.
Oh, okay. So they're open, huh?
They are open. Everything's open, and since tomorrow we are not going to have any major restrictions. Tomorrow, all restrictions and not all, but mostly.
Really, it's the same here. It's
The same?
June 1st. A lot of restrictions are dropping. They're opening the parks and the beaches.
Yeah.
Which is
the only will be restricted are the theaters, but they will be open, but less people will be allowed in, and those like festivals and these things are not on sports, but otherwise everything's normal, back to normal.
Okay, Vlad, we'll start in a few minutes. Okay,
yes,
10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett, broadcasting from Miami Beach, home of Neurosurgical TV. Today we have the pleasure of having Vlad Benez, MD, a neurosurgeon from Prague, well-known educator and a great guy. Hello, Vlad.
Hello.
It's all yours.
Thank you. I did something wrong, I guess. No.
Yeah, you're going into Zoom again.
Need my glasses. Sorry.
You want to get out? You want to get out of that?
Yeah, screen sharing.
There you go.
Here we go. I must go. All right. Is it okay, John?
Yeah, it's good. Good. You just open it up.
Hello, everyone.
Beautiful.
Today I'm going to talk about the arachnoid membrane and cisterns, which I feel are extremely important for a neurosurgeon. And it will not be really that long, because I believe that any message which is important takes only short time. So I will be like 20, 25 minutes. So let me start with arachnoid membranes. We have two major disciplines in neurosurgery. They sometimes are even deemed as subspecialties, which I do not believe, but let's say that they are. So first is vascular, mainly aneurysms, and then skull-based, meningiomas. Many people are doing both, but there are also people who are doing only one. And what's important in these two are that they are completely different space, because the aneurysms are in the subarachnoid surgery. It's cutting the arachnoid and open the cistern, which is completely different space from that where we go in meningiomas, in skull-based meningiomas, where we try to lift the arachnoid. We do not try to cut through the arachnoid, and we try to preserve the membrane, because as long as you are outside the arachnoid, you do not harm the brain. So these are the two most important differences in virtually the same anatomical region. Take a look on this aneurysm of the ophthalmic artery. It's an easy, very straightforward surgery, but check that there is no arachnoid at all. The arachnoid is completely dissected, and the aneurysm is in the subarachnoid plate, inside the arachnoid cisterns. And this is what you can see when you dissect everything in the skull base, in the cell region, from basilar bifurcation to the opposite side, PCOM to the opposite side, third nerve. Here we have the ACOM complex and everything. And all this is when the arachnoid is dissected. You are inside the arachnoid, you are in the subarachnoid space. You may even do lots of aneurysms at once from one approach only. And you are still in one space, in the subarachnoid space. This is completely different. Here we have a typical tuberculum cell meningioma. And as you see through the surgery, here is the arachnoid which is being lifted from the tumor. You just lift the arachnoid. You see that the arachnoid is not cut. It's preserved as much as possible, because as long as you are outside the arachnoid, you do not harm the neural structures. We have in meningioma 3 types. This is Yashargil, of the growth of arachnoid or relation between the arachnoid and the brain tissue, which is non-adherent, which is this region where this tumor was, and you see that it's completely undamaged. Then we have adherent, where already are very firm relation between the arachnoid and the tumor, and you see that you preserve the cortex, you preserve the vessels, but you are already nearly in between. And then there is adhesive type of the growth, which is over here, where the arachnoid is spent and the tumor penetrated the arachnoid into the brain. We all know that, and we all respect that. And what's important on this is when you realize in advance what you are going to do with the arachnoid and where the arachnoid will be, you may very well plan your surgery. These two cribriform plate meningiomas are exactly the same size. They are different in 2 respects. First, in this tumor, you have bilateral edema. In this tumor, the edema is unilateral. In this case, the anterior cerebral arteries are pushed to the side. In this case, the anterior cerebral arteries are in the midline. And this is the sketch of what it means. In this case, it means that the left frontal lobe will be covered by 3 layers of arachnoid. One of them the original, and the other 2 being pushed there by the anterior cerebral artery. So this part of the brain is very well preserved and very easy to be dissected without any damage to the cortex. This is just the opposite. When the vessels are in the midline, you see that both frontal lobes are covered by single arachnoid layer only, which may not be sufficient. And we all know that these tumors tend to grow into the arachnoid rather frequently. Let's see what it means. This is at the end of surgery of this small tumor. And you see that when you finish the surgery, respecting the arachnoid layers, your opposite side first nerve will remain intact, still covered by the arachnoid, and the patient will retain smelling. So whenever the tumor is slightly to the side and whenever it's not growing into the both sides, you may preserve the olfactory nerve rather easily. The same thing is in the central region, in parasagittal meningiomas. When the tumor origin is in front of the motor stripe, which is over here in reddish, then it means that the sulcus retains two arachnoid membranes. Each sulcus has its own, and then the motor strip is preserved by two layers of arachnoid, and you are quite safe in your endeavor. Just the opposite, when the tumor has its origin directly above the motor strip, then there is only one single layer of arachnoid, and of course the surgery then is much more difficult and much more dangerous. It's seen on these when you monitor during the surgery, you move, you are resecting the tumor, and you see that there is already some response even from the resection cavity, but still the motor strip is covered by the arachnoid and you are safe. The same thing here, you move, you get your response, and you see that you can resect safely because your brain is intact. Another one which is slightly posterior, but this is the motor strip, so it means that the motor strip on this side will be just anterior to the tumor. Here are the tracts, here are some another depiction, and here we go through the surgery. Again, you go with your monitoring, and you are trying to preserve the arachnoid, and at the end you have these images with completely intact arachnoid. Here is the motor strip just anterior to the low system reinforces might affect your audio quality. Do you hear me well?
Yeah, it's kind of breaking up a little bit, but it's okay.
Okay, so it's just some silly warning. Let's go ahead. So we started studying arachnoid as we didn't feel that the anatomical studies were sufficient, which were published. This is the only one which is really comprehensive. It's by Kuruc, and all these beautiful pictures are acquired with the help of endoscope, and it's really very thorough. It really shows almost everything, but it's rather difficult to get oriented in the images. It's rather difficult anatomy per se, and these publications should be probably the first to study, but difficult to understand. This is what in Roton's anatomy, which is the basics for all of us, is the only mentions of basal cisterns, and you see that especially the lateral sides are rather arbitrary. This is not really based on any anatomical study. This is based probably on literature, because otherwise Roton has always excellent images of himself. Only in cisterns he is showing like this, and you see that in the studies of anterior clinoid, which are excellent by any way, the arachnoid is already missing, and he doesn't mention it in the text too much. So what we started were these studies of arachnoid. This is a specific technique which we are doing with the colleagues from Tours, France. You soften the bone, then you resect the bone, and only after you open dura, and you see that the arachnoid is very nicely preserved, and you may really nicely study all the cisterns, like chiasmatic here, carotid cistern, which is probably the most important one, interpeduncular cistern, and you see all the structures which are hidden there behind the carotid, behind the arachnoid. You will see all the layers which are here. This is the Lilienquist membrane, for instance. Here is the carotid, when after the opening of this little window in the arachnoid. This is another technique where you do not use any perfusions, and again you very nicely see the arachnoid layers, and you may appreciate how difficult and individual, unfortunately, it usually is, that there are only these little fibers somewhere. It's really like a layer of the arachnoid. It's really permeable because the CSF flows freely from one cistern to the other. So this is something which you need to learn, and possibly as much as possible, because you will see that, for instance, ocular nerve, if you're coming from above, is well covered by the arachnoid. To get it, you really must dissect the arachnoid, and you would like to stay outside these layers just in space, which you need, for instance, when you need to reach the vascular aneurysm. In this case, you will cut only in the depth, not along the head nerve. Very similar head nerve, posterior communicating artery, and you see that the posterior communicating artery is behind the wall of arachnoid. It means in the subarachnoid space in the cisterns, not outside. The very strange is the region of CP angle, where the arachnoid is constituted by several layers, which are differently spaced, like 7th, 8th are truly anterior, when looking from posterior, from the surgical view. On the other hand, 5th nerve is usually much more free, and the arachnoid layer goes more in front of the tumor, and 7th, 9th, and 11th are well covered and well protected. Here it's dissected, and you see the free nerves in the cerebromedullary cistern. So what is to be said about the arachnoid? That planning the approach with advanced knowledge of the cisterns and expected layers is paramount. It's important not only for skull base like meningiomas, it's important even for aneurysms, because you just would like to know, and you should know, in which cistern you are and in which cistern you are going to find your aneurysm. And to guess from which layer will be where, it's important to define the origin of the tumor as much as possible, because the tumor origin is rather tiny, the original one. And this is where the cistern is penetrated. Where the tumor origin is, that's exactly the cistern in which the tumor will be. And of course, if it's a cerebropontine cistern, you would expect 7th, 8th, and 5th nerve to be directly in the same cistern as your tumor and as your surgical endeavors. This is the difficult space for us as neurosurgeons, and these are the cisterns you are going to attack at the skull base, starting from olfactory, going to chiasmatic, which is rather tiny in a way, the carotid cistern, which is very important because that's usually the cistern from which you drain the CSF during the cellular region surgeries. Then you have ambient and crural cistern. Then the important cistern again is the cerebropontine one and cerebromedullary, and of course the interpeduncular cistern for basilar tip, prepontine, which is not that frequently entered, and premedullary, again, not that frequently entered, because there are not that many meningiomas growing in these places. You may guess what the layer will look like. This T1 with Gado, it's not really a surgical image. The surgical image is the T2. And here we have the meningioma. According to these concentric lines, you guess very well where the tumor origin is, and that you may expect the arachnoid to be covering 7 and 8, which are here, that there will be a good plane of dissection, and probably at this spot where is edema already, the arachnoid will be spent to some extent, and again the plane of cleavage with your arachnoid over here will be very nice and easy to get. These are the two tumors which look rather similar. On the other hand, they are completely different. One of them is anterior clinoid, the other is posterior clinoid. Here the vessels are in front of the tumor, and actually this tumor is posterior to the Lilienquist membrane. So by definition, this tumor should be coined as posterior foci tumor, which it is not, but this is the one which is difficult, because your arachnoid will hinder you and will help you from the front, not from the posterior, because here it will be an interpeduncular system, which will be really difficult to resect, unlike this one, which will push all the arachnoid away from your angle of approach. Exactly the same thing, the Lilienquist membrane anterior to the tumor, and you are in the most important region after traversing the arachnoid layer, which will not anymore help you that much. This is from posterior. This is a nice cholestatum when you set it, you get to the interpeduncular cistern and you will see the posterior clinoid process. And here you see the clearing membrane from posterior, which is again a little of your approach from posterior. And again, it's a layer of arachnoid, which is your limit of resection. It's usually these limits, which gives you the arachnoid. Meningioma then is the arachnoid membranes. You should respect the arachnoid as much as possible and always, if possible, you should have advanced knowledge of the membrane and cisterns in which you will enter, in which you will not want to enter. You will not cut it unless necessary. You will lift it, which is probably an important technical point. And everyone should study the anatomy, which is not that easy because there are not that many possibilities. And just switching for aneurysm surgery, for subarachnoid surgery, it's exactly the same. You need to know about the arachnoid membranes. You should respect it. Opening only the cistern you need to open. You should have advanced knowledge of the cistern where the aneurysm will be located. But you will cut the arachnoid. Do not tear it. Please just cut it. Use the scissors, and you will again need to study the anatomy. Here's the tumor which is penetrating more cistern than one, which is not really that unusual in the skull base, but very rare in, let's say, sphenoid wing and even in tuberculum cell. But these tumors coming from posterior fossa into interpeduncular system, at least in CP angle and in interpeduncular, at least in 2. And even the surgery should respect this fact. It will be done, or at least in my hands, from posterior further part in the CP angle will be resected. Then you will open the tentorium this V fashion. Then the piece which is subtemporal, and that's last. You will resect the tumor from interpeduncular system, leaving behind the tumor which is in cavernous sinus. I do not think that entering the cavernous sinus in order to resect meningioma is a sensible way when there is always gamma knife behind the corner. So what you will first see in CP angle will be the 7th, 8th, then ICA, and the 5th nerve, all covered by the at least one layer of arachnoid, and you will be going upwards and anteriorly. You will have your 5th and 6th nerve very soon. Then you will get to the nuisance of the 4th nerve, where obviously is the limit of the first cistern, because here is the ambient cistern which you must traverse, and check that there are arachnoid layers within the tumor nodules. You see it and you will cut it. And then when you are at the end, here is the arachnoid cut in order to show you the anatomy of the region from supra-infra approach. This is the contralateral posterior clinoid, contralateral P2, and this is the contralateral optic tract, and this is the pituitary stalk, and this is the ipsilateral side. Again, posterior clinoid post-process, again, posterior cerebral artery and superior cerebral artery, which is running towards us, and the third nerve. And this is a little more medially in the interpeduncular system. You see the basilar artery, superior cerebral and posterior cerebral. And here you see the Lillienquist membrane, which is the anterior limit of the approach, which was not penetrated by the tumor. This is the tentorial cut, and this is the depth of the region. This is the whole approach. This is the cerebral hemisphere. This is after and only the piece in cavum Mekeli and in cavernous sinus was left behind for the future radiosurgical treatment. Another case of very small meningioma of the anterior clinoid optic canal region, which really shows the problem of vision always. And you see that during the surgery, the arachnoid is preserved. This is the optic nerve, which is already free. Here is the arachnoid, and here is the arachnoid, which is preserved as a border against the vasculature there. Another case of this time tuberculum cellae meningioma. Again, see that the arachnoid is preserved as much as possible, and you cut it only there where you really need it. One optic nerve, the other optic nerve. Again, the arachnoid is lifted from the skull base, and here's the tumor. The surface of meningioma is never smooth, it's always rough. If you have the smooth surface of meningioma, it means that it's still covered by arachnoid, and it means that the vessels will be directly on the tumor. As soon as the surface of your meningioma is rough, you are in the proper dissection plane. See that here the chiasmatic cistern is preserved and only push backwards, again preserved here. On the other hand, not a single layer of arachnoid here in the aneurysm surgery. Okay, there just to conclude and not to take your Sunday time too much, respect the arachnoid, know about it, and really do as much as possible to cut it only reasonably. Arachnoid is a friend. This is what my big friend Imad Kanan is always saying, and it's perfectly true that arachnoid is your surgical friend. So learn the arachnoid system's anatomy and learn the relations with normal structures. Thank you. That's all for today.
Okay, Vlad. Yeah, let me just get you off the screen share. Yeah, we apologize to the listeners for the audio, but it's either that or no Vlad.
Yeah.
Okay, we're going to open it up for discussion. So anybody have any comments or something they'd like to say to Vlad? Don't be shy.
They are.
Yes, today.
Yeah, it's Sunday. You can't expect people to be too active.
I know. Let me get this camera set up here. Okay.
Hello, everybody.
Okay, there we go. Good morning.
Hello, good morning.
It's good morning and good afternoon. It's actually a holiday in our region during this coronavirus. Thank you for your presentation. Actually, it's very important for any neurosurgeon to learn how to dissect during the arachnoid layer, which is protect the dissection and make it the safety signs for successful treatment. Actually, what your comments for the arachnoid membrane, which is in the trigeminal region during the vascular decompression. In some cases, we found very thick membrane, which is really more than arachnoid, but maybe they call it the trigeminal membrane or something like that. But it's the key to discover the loops under the nerve. So what's your comment on such a situation, please?
Yeah, there are three regions where the arachnoid is really thick and nearly impenetrable. The first is, of course, the Lilienquist membrane. The second is the pineal region, the posterior wall of the ambient cistern. It's always thick and you do not see through, unlike in all the other regions. And the third place is exactly the trigeminal nerve area, where the arachnoid is sometimes really very thick. We do not call it membrane. That's a good term. We probably should start because it's a good term. But in trigeminal neuralgia, what you are going to do is the decompression. So you need to get to the vessels, and the vessels are in subarachnoid space. So in this case, you really need to cut it, and you need to dissect the arachnoid away from the nerve. If that's what you mean.
Yes, that's a part of it. But I think, do you think that this thick membrane play a more role in the pathology? Because in some cases, I had just a few cases, about 10 cases on trigeminal decompression during the last year, because just we finished nearly finished our war time, and we are back to microsurgery maybe 1 year just. So I have 10 cases. I have maybe 4 of these 10 cases very thick membrane, which is covering the vessels with the trigeminal nerve. And I think what I just cut it, I released the vessels, and it was playing very compressing and in the pathology itself and the etiology, I think, of the pain.
I don't know. You know, unless I find an artery in the trigeminal neuralgia, I'm not really satisfied. I don't believe much into the venous compression, and per definition, I wouldn't believe into the compression by the arachnoid. I believe that one of the main mechanisms is the pulsation of the artery, and on the other hand, I've seen several small meningiomas where the only symptomatology was trigeminal neuralgia, and during the tumor resection there was no artery in the vicinity of the nerve. So probably some mechanism like that may be there. I wouldn't rule it out, but I would very much hesitate to do surgery. And I would be very nervous if at the end of surgery, I would have only thick arachnoid membranes, which I have cut. Were you successful in treating the neuralgia in these cases?
In these cases, when I did not find any vessels, actually I do as usual, I do some manipulation treatment and then combing the nerve, dissection the fascicles in longitudinal. And I have all the cases had a good and great result, except one, he had multiple sclerosis. And you know, this is something
that's different issue.
Yeah, all the other cases, I did not find any vessels. I did my manual manipulation three times in bipolar without any electricity, of course, and then combing the nerve, longitudinal dissection of the fascicles, and they are happy. The patients are happy. Yeah.
Good.
Yeah.
Good.
Thank you. Do you suggest, in your experience, any reference for the arachnoid membrane to study, like part 1 of Yazorgil book, or what you suggest for? Because the arachnoid membrane really it's our guard in the tumor surgery or any microsurgery. So, do you suggest any reference for reading for?
No, not really. Only the Skuruc articles are there. And otherwise, it's always difficult to write something and publish something after Yazorgil. And Yazorgil has this adherent, adhesive, and this thing. And as far as I know, no one has ever after did any work on this. It will be important, you know. It's 35, 40 years old by Yazorgil, but he was such an icon that no one really touches the topic, probably.
Yes, there's some on the internet now for just like you said, that Liliequist membrane, or some parts they concentrate on the arachnoid membrane. But the most problem is that Professor Yazorgil, I met him last year, he's now preparing for publishing book for the anatomy of the brain. So he will
No kidding.
Yes, he's working for that now.
Okay. Yeah, that's good. So we shall have at least something, and it will be from the most experienced hands.
Maybe.
I hope that Ugur Ture will somehow help him.
Sure, Ture, he's the right hand also. Another point, maybe the most important for the concentrating on the arachnoid membrane is the opening the stem to relax the brain. This is very, very important for training. Yeah, that's it.
Yeah. Exactly. It's Sherian cisternostomy, but what's good is that always in the cell region, when I start, the first maneuver is to open the carotid cistern. Then wait for a while as the CSF releases, and only then go, let's say, for tuberculum cell meningioma. But since that point, I'm just lifting the arachnoid. I don't cut the arachnoid in this region. I cut only open, very, very tiny opening of the carotid cistern, and that's the space from where you get the most CSF. You never get it from chiasmatic cistern or from any other, but carotid cistern is very good for draining the CSF.
Yes. Thank you very much for your remarks. Thank you.
Thank you too.
Okay, more comments or questions from the panelists? Don't be afraid. This is your chance to be with Vlad.
Okay, John.
No, come
It's
on. We just
probably
gotta,
someday.
we gotta shake them up a little bit. Come on, you guys. Let me see. Okay, I'll have to pick some names here. Unfortunately. Hello, Adnan. How you doing?
Hello, lad. I'm fine. How are you? Sorry, I was a bit late, so I couldn't attend the whole lecture. But I always listen Dr. Vilad in PSN, Pakistan Society of Neurosurgeons lectures everywhere, and he's very famous among all Pakistanis as well. A very excellent professor, and inshallah we will learn in future, like always, and you will invite for more and more knowledgeful lectures. Thanks.
Thank you.
Okay, then. Thanks, Adnan.
Very
Okay,
good.
anybody else want to comment? Otherwise, we'll
If
close.
there's
I
nobody,
guess.
I can share my notes if you
Go
don't
ahead.
mind.
Fine, fine.
Fine.
It's our time. Actually, maybe a few years ago, Professor Al-Mufti, he was working for preparing for lecture on the meningioma. And I was discussing with him, I did my fellowship with him. I told him, you are working and taking care about the arachnoid cyst like the Spider-Man. He likes it so much, and he put it in his lectures now that the neurosurgeon is dissecting the fibers of the arachnoid like the Spider-Man, and to be safe in this point. I want to tell it you about it.
Yeah. I didn't mention it, but that's probably Samal Mufti's one of the major contributions in meningiomas, when he has written, and it's an old article in early 90s, and it was probably afterthought, not in advance, that the carotid artery is not covered by arachnoid for millimeter or two as it enters dura.
Yes,
and
yes.
We all know that the meningioma, as soon as it's outside dura, it's a much more aggressive tumor. And we all had a problem with carotid artery that we told them when we were resecting the meningioma in this region. Almost everyone has injured carotid artery at least once in life, and it's because of this little tiny stretch of the artery which is not covered by the arachnoid.
Yes, yes. He called it. It's about. I think it's very near to the carotid ring, which is not covered by the. Yeah, and this is very important in the the operation, or you will have the complications.
Exactly. Exactly.
Yes, he mentioned that. Yes, you know, he works a lot on the meningiomas, so he's the expert. And always he advised us, when you dissect the meningioma, always keep the arachnoid intact and intra-arachnoidal dissection. Make your intra-arachnoidal dissection, and this is very important to me in practice.
Exactly, exactly. It's what Iman is saying, that arachnoid is a friend.
Yes.
It's your surgical friend. And strangely, on this article by some, is that those were the cases from Saudi and from Egypt. Those were not his American cases, and he only had CT. So those were probably, he doesn't write it there, but those were probably surgical observations, not the radiological observations of the carotid, which was really a marvelous piece of work by him.
Yes, I think the most important part of his series, he did it in Saudi Arabia, because when he opened a new department in King Faisal in Riyadh, he had a very huge number of tumors and very large number of tumors. And he did it in about 6 years, and he left back also after that to the United States. In the United States, you know, of the tumor 1 centimeter, 2 centimeter, they operate them. And in our region, you will have, like India, nothing like India actually, but you see the cases in India and in Africa, they have a very huge number of cases and very huge, large tumors in size. So the most of his series actually was in Saudi Arabia, and then he continued in Arkansas with Professor Yazurgil and Ali Krishna.
Right. That's true. That's true.
Yeah.
That's true. And then he diverted or deserted to all those silly chondromas and chordomas.
Yes.
Which are, well, difficult. And it's India always, velore. in Europe, we have several Indian neurosurgeons who left India because of the number of cases, that they didn't have time to follow the cases, that they didn't have any clinical follow-up, and that they were unhappy about it. So despite the high numbers that like Atul Goel is showing, they left for Europe and they are doing excellent work in Switzerland, Britain. There are several of them.
Okay. Okay.
Well, Vlad, I guess we can add that feature we were talking about where I'm testing your literacy, because you told me that you have read all those books in your study. So we're gonna do we're gonna pick up a random book and see if you know about it. Okay, you see.
To
Okay,
recommend the only one.
okay, okay? Go to the license plate. Go up to the license plate in back of you and pick out one of those black books.
One of those black books behind the. You mean
Next to-
Arizonian license plate?
Well, yeah. Next to that, there's a black book. Just pick it out, and I want you to tell us about it. We're testing Vlad because he told me he's read all those books in his study.
This
This
is funny.
is a random selection now, a random.
You know, this is funny thing that I told you that there is nothing medical. And this is nearly medical because those are the tales of the Czech science.
Okay, what is
You
it?
may read for yourself, of course.
Okay, what is the book? What's the book about?
Oh, that is, we had an excellent scientist who did a polygraph. He got a Nobel, he won a Nobel Prize for that. Then we had an excellent guy who was the original inventor of those contact lenses. He produced the stuff and he patented it. What was next? We are extremely good in Egyptology.
Well, you haven't told me the magic thing. Have you read that book, or is it brand new?
I do not know. It's not. It looks brand new, so I probably didn't read it. And it's a gift.
So I caught you. I caught you.
You caught
haven't
me.
read.
You won. Okay, you won.
I got.
You know,
lucky.
John, I have a rule that each day I should make a good deed. You know, so this was a good deed for today that I let you catch me.
Okay.
Okay.
Okay. Thanks, everybody. We'll see you tomorrow. Thanks, Vlad.
Thank you.
very much.
Bye-bye.
Thank you.
Bye-bye.
Take care.
Bye-bye.